And today I get to talk to you about one of the more interesting and emotional topics going on in epilepsy. And it comes at an unprecedented time in the history of medication, because it's really the first time that a potential treatment option has been so feverishly pushed by people with epilepsy and their loved ones, despite the fact that it's still illegal according to the federal government. And as a result, the science has really lagged behind. This is an emotional topic. This webinar is not intended to sway anyone either in favor of or against the use of medical marijuana. The intent is to present what we know. And so, since this is such an emotional topic, I wanted to start with a few quotes that sort of highlight the reactions that medical marijuana gets from different people. John Lennon referred to it as a harmless giggle. President Barack Obama said, "When I was a kid, I inhaled frequently. That was the point." And this was an important statement because it really was the first time a sitting president had admitted to smoking marijuana in his youth. Arnold Schwarzenegger referred to it as just a leaf, not a drug. The chief of the LAPD said, "Casual drug users should be taken out and shot." Bob Marley said music and herb go together. It's what allowed him to be so creative. Jennifer Aniston said, "I enjoy smoking and see no harm in it." Governor Chris Christie says it's not the kind of quality of life that we want here in New Jersey. There's a lecture title that I thought was really interesting that says, "The grass that makes the other side of the hill look a little greener." But probably my favorite quote comes from Thomas Jefferson, where he says, "If we think them not enlightened enough to exercise their control with wholesome discretion, the remedy is not to take it away from them, but to inform their discretion by education." And so today, we're just going to try to educate ourselves a little bit with respect to the information that we have about medical marijuana. So we can look back thousands of years and see evidence of humans using cannabis. They used it to make rope and clothing. They used it as livestock feed. They used it in recreation, religious ceremonies, as well as for medication. Some of the earliest reported medical uses were found in China, approximately 2700 BC, where cannabis was used for gout, for the treatment of rheumatism, malaria, constipation, and menstrual pain. In medieval times, we even see that it's been used for epilepsy. And up until mid to late 1930s, marijuana was the most common analgesic used. You could walk into a pharmacy and get it without a prescription. It wasn't until the Marijuana Tax Act of 1937 that its access became limited. And by the mid-1940s, it was no longer available. In 1972, the federal government labeled it as a Schedule V drug, meaning that it was a drug without any evidence of accepted medical use. So this is what marijuana looks like, at least from a chemical perspective. It's an incredibly large compound. It has well over 500 different molecules and at least 80 different cannabinoids. But when we talk about the cannabinoids, there are two that we pay really close attention to when it comes to marijuana for either recreational uses or for medical use. And the two that we pay attention to are THC and cannabidiol. THC is what's thought to give you the psychoactive effect. It's why people on the street get it to get the high. CBD is what's thought to give you the therapeutic effect. And that's what tends to be important when we think about treatment of various illnesses using medical marijuana. The way that we think that it works is that the cannabinoids bind to receptors within our brain, and by binding to these receptors, they modulate other biological chemicals. And by modulating these chemicals, they cause the release of neurotransmitters in the brain that then go on to cause changes in the cell as well as changes in gene expression. It was found that human beings, we have an endogenous endocannabinoid system. We have a group of receptors in our body that marijuana binds to. CB1 receptors are found within our central nervous system, so within the brain and the spinal cord, whereas the CB2 receptors are mostly seen in the peripheral organs and within the cells that are associated with the immune system. It's thought that our body can produce on demand its own endocannabinoids, and it tends to do this whenever the cells in our brain, when the neurons are increasingly excited and overstimulated. And our bodies produce these endocannabinoids in order to sort of dampen that excessive neuronal stimulation. I said that marijuana is an incredibly big substance, and we know that it tends to bind GABAergic receptors or GABAergic neurons. And these are the major inhibitory neurons within our central nervous system. These are the neurons that tend to dampen neuronal excitability. But because marijuana is such a big substance, it's also unpredictable. And we know that some of its components can also bind to glutamate neurons. And glutamate is the major excitatory neurotransmitter within the brain. And so by binding to glutamate neurons, it can also produce excessive neuronal excitability. CB1 receptors are located all throughout our brain in various regions. We can find it in the hippocampus, which is responsible for memory, within both cortexes, in the basal ganglia or cerebellum, responsible for motor movements, as well as in the spinal cord and the peripheral nerves. The place where we tend not to see the CB1 receptors are in the thalamus, or at least most importantly for this presentation, within the portion of the brain stem referred to as the pons. And this is important. The pons holds structures that are vital for some of our basic respiratory systems, our ability to breathe, as well as our cardiovascular system. And this is why there have been no attributable deaths to marijuana, because it does not affect the pons and therefore does not affect the control of your heart rate or your respiratory rate. So I said that CB1 receptors can be found in all different parts of the brain, with the exception of the pons and maybe the thalamus. But depending on where in the brain the CB1 receptors are stimulated, sort of gives you the different symptoms that you may have. So for example, the hypothalamus is associated with control of appetite. And so stimulation of that can cause people to be incredibly hungry. The amygdala is responsible for things like anxiety and fear. And so stimulation of that can make people incredibly anxious. The cerebellum is responsible for fine motor control and coordination. And so overstimulation of that can make people a little bit clumsy. We know that traditionally speaking, marijuana is associated with a lot of different symptoms that maybe the user is not trying to experience. But for example, marijuana and the munchies. And so stimulating the CB1 receptors that are associated with the olfactory bulbs, the bulbs that are responsible for smell, helps somebody to smell food more acutely. And as a result, it also causes them to taste food better, which can cause them to feel hungrier. Stimulation of the hypothalamus can also release the neurotransmitter ghrelin, which stimulates hunger. We know that marijuana is often associated with a very pleasurable feeling, and that's because stimulation of the nucleus accumbens can increase dopamine. Dopamine is often associated with pleasure, and it's actually the major neurotransmitter when it comes to our body's reward pathways. And so stimulation of that is going to have us feeling good. We also know that dopamine is associated with psychosis. And so excessive levels of dopamine can cause people to develop psychiatric symptoms. And so you can find libraries full of articles that suggest that marijuana is associated with psychosis. Stimulation of the cerebral cortex. These overstimulation of the CB1 receptors located in the prefrontal cortex can cause people to be apathetic, to lose interest, to have difficulty attending to and completing tasks, and can cause them to have poor planning and decision making. So again, this slide shows that CB1 receptors tend to be concentrated in various parts of the brain, and depending where the receptors are stimulated gives the symptoms that the person experiences. So when we think of the endocannabinoid system, and you think of the way that two neurons communicate with each other through the release of chemicals, we know that the binding of marijuana or CBD to the endocannabinoid system, to the CB1 receptors, then affects how neurotransmitters are released. And by affecting the release of neurotransmitters, they then exert their effect on the person. So CBD does not activate either the CB1 or CB2 receptors. It's THC that does that. It's probably the reason that CBD is not associated with any high. But it does interact with other systems within our brain, and we know that it can inhibit a lot of the other systems in our brain, and it does have an effect on the amount of calcium within cells. CBD also tends to exert its influence on THC. So it may be the reason that people do get some beneficial effects from marijuana. It tends to reduce the psychoactivity of THC. It allows for people to tolerate much higher doses of THC than they normally would be. And so when we think about CBD and THC, we often think about them together because they essentially go together. It's the ratio of the two drugs that matter. And so when we're talking about the use of medical marijuana for epilepsy, we need for that plant to be high in CBD and low in THC. Because those people where they're taking a plant that has high CBD to THC ratios are less likely to develop psychotic symptoms. When people get the drug from the street, they tend to get drugs that are high in THC and low in CBD because they're trying to experience those psychotropic effects. So the entourage effect just suggests that you need all the chemicals within that plant in order for it to exert its therapeutic effect. So we couldn't just give somebody CBD without THC or THC without CBD and affect it and expect for it to be medically useful. So this was a book by Paul Harding. It was actually his debut novel. The title of the book is called Tinkers, and it won the Pulitzer Prize in the year that it came out. And the book essentially follows the memories of a man who is dying. And as he lays there dying, he begins to think about a lot of things that he's seen in his past. And one of the things he thinks about is a conversation that his father had. And his father was a man who had epilepsy. And so his father was asked what it felt like to have seizures. And he provides this answer. The actual seizure was when the ball touched the flesh, and in an instant so atomic, so immaterial, nearly incorporeal, that there was almost no before and no after, and Howard became pure unconscious energy. So we're going to stick with the theme of electricity, and we're going to simplify what happens in the brain when somebody's having a seizure. And we're just going to say that when somebody has a seizure, that there's a sudden surge of electrical activity in the brain. To diagnose somebody as epilepsy, we tend to say that they need to have 2 or more unprovoked seizures. That's the sort of traditional definition. As of this year, we also say that if somebody has had 1 unprovoked seizure, but they have tests, whether it's EEG or MRI, that suggest that they're at high risk of having future seizures, then they can also be diagnosed with epilepsy. For some people, that burst of electrical activity, that sudden surge of electrical activity, can happen just in one particular part of the brain, and we often refer to that as focal or partial epilepsy. Whereas for other people, that burst of electrical activity happens throughout their entire brain, and we refer to that as generalized epilepsy. It's important to know which is which because it helps in terms of guiding treatment options for that person. There are lots of different causes of seizures, and we often say that one person is entitled to have 1 seizure throughout their life. And as long as their testing is normal, they don't necessarily need to be started on any anti-seizure medications, of which there are a lot. The list grows every year, and we're, at this point, well above 20. There are also devices, such as the vagus nerve stimulator, that can be used for the treatment of epilepsy. Like I said before, there's a fairly long list of anti-epileptic drugs, and that list seems to be growing every year. We can also use diets in order to treat epilepsy, as well as epilepsy surgery. But some people have what we call medically intractable epilepsy, meaning that their seizures really don't respond to any medications, and they continue to have seizures despite being on medications. They may continue to have seizures despite epilepsy surgery or despite the implantation of a device. No single step in treatment defines somebody as intractable, but after failure of each drug, statistically speaking, the probability that that person will have seizure control gets lower and lower. It never quite approaches 0, but it can certainly be less than 5% for somebody who is on as many as 4 anti-seizure medications. We know that often people who have medically intractable epilepsy also have some comorbid conditions, and some of the comorbid conditions that we often see with medically intractable epilepsy include things like autism, developmental delay, and delayed language. Epilepsy or seizures is often a symptom of something. So if there are parts of the brain that are not functioning properly, then that increases the risk that somebody is going to have epilepsy. We do see people who have epileptic encephalopathies, and by that we mean people who have medically intractable seizures, but also have really significant cognitive impairments. And often the debate is, what's causing what? Is it the frequent seizures causing the cognitive impairment, or is it the cognitive impairment that's causing the intractable seizures? And the reality is that it's probably some vicious cycle of both. Now in 2013, just about exactly 2 years ago, Sanjay Gupta gave a documentary on CNN which essentially followed his evolving views of the use of medical marijuana. And in his documentary, one of the people that he followed was a little girl named Charlotte, who had medically intractable epilepsy and who was having hundreds of seizures, not responding to any medications. And so her parents decided to try to give her medical marijuana for the treatment of epilepsy. And so they found that there was a dramatic decrease in her seizures. And so the particular plant that they used became known as Charlotte's Web. Okay, and Charlotte's Web has a very specific ratio of CBD, higher CBD, and lower THC. So the theory is that our body has an endocannabinoid system. And by binding the receptors within this system, you can dampen some of the excessive neuronal activity. And that sometimes our body can also do this on its own and produce its own endogenous cannabinoids. We know that stimulation of the CB1 receptors tends to decrease the amount of calcium going into cells and increase the amount of potassium leaving cells. Seizures are often associated with sustained neuronal excitability and elevated levels of intracellular calcium. And that hyperexcitability that occurs in the neurons during a seizure may be able to stimulate the body's own endogenous cannabinoids, resulting in activation of the CB1 receptors, which can then influence seizure activity. So this is a look at THC and CBD again, because in order to be able to stimulate the CB1 receptors, you need to have both components of the drug. And that's what Charlotte's Web has. Like I said before, it has very specific ratios of CBD to THC. Again, this just says activation of CB1 receptors can modulate neuronal excitability, and that neuronal excitability is often associated with seizures. But this is theory, because there are no studies that have been done in humans to see if this is actually the case. So at the end of 2013, the American Herbal Pharmacopoeia released their first two-part cannabis monograph. And this was important because it was the first time that it classified cannabis as a botanical medicine alongside with other widely accepted complementary and alternative medications. Looking back, we know that we have well over 150 years of anecdotal evidence for the treatment of epilepsy using CBD. The Cochrane Data Review Group wanted to see if we had any true scientific trials that exhibited what the anecdotal evidence showed. And so what they did was they knew from animal models, especially research on rats, that marijuana appears to have some anti-epileptic effects. But they wanted to see if that was the case in people. They wanted to see how effective marijuana was in the treatment of epilepsy, and they wanted to do this by finding randomized controlled trials. And their primary outcome was to see if there was seizure freedom at 1 year or more, or if there was 3 times the person's longest interseizure interval. So what they ended up finding was only 4 randomized reports. And the 4 reports had a total of 48 patients. And in these 4 different studies, the comparison was made between marijuana and placebo. And out of the 48 patients in these 4 studies, what they found was there were 4 patients who had had CBD that had been seizure-free for a period of time, And there was one patient who had had placebo that had been seizure-free for a period of time. But for the most part, there was no other significant information coming out of the studies. When the American Academy of Neurology looks to classify therapeutic trials, they tend to use 4 different classes. The first class is a perfectly done randomized controlled trial. And a class 4 study is a trial that has a really high risk of bias and is really no better than expert opinion. What they found was the 4 trials that were found within the Cochrane database review, all 4 were class 4 studies, meaning that all 4 of them had a really high risk of bias because they were performed by somebody who was a member of the treatment team. So they knew which patient was getting placebo, which patient was getting the actual drug. Patients didn't get different treatment options. Oftentimes the statistics were not that good and they were not reproducible. And so all 4 studies were all really low quality studies. And from a classification perspective, we're all at the lowest class. So the American Academy of Neurology wanted to see if they could do their own database review. So they got a committee of neurologists together to check to see if they can find information about the safety and efficacy of the use of medical marijuana for a selected group of neurological disorders. And so the disorders that they looked at were different symptoms of multiple sclerosis. They looked at some of the dyskinesias of Huntington's disease, some of the tics of Tourette's, and they also looked at the seizure frequency seen in epilepsy. And so they did a huge review of different databases, and they ended up finding a little over 1,700 abstracts. And based on their inclusion-exclusion criteria, out of that 1,700 abstracts, they reviewed the full text of 63 articles. And then they found that only 33 articles met their inclusion criteria. So when they asked the question, do cannabinoids decrease seizure frequency, they didn't find any class 1 to class 3 studies. They only found 2 class 4 studies, so studies that have really high risk of bias. And what they found from those 2 class 4 studies is that they did not demonstrate any significant benefit nor show any significant adverse effects after a period of 18 weeks of treatment. And so their conclusion was the data is insufficient to support or refute the efficacy of cannabinoids for reducing seizure frequency. They also concluded that there wasn't enough information to show if marijuana, whether it was smoked or taken some other route, was safe and effective for the motor symptoms of Huntington's, the tics and Tourette's, the cervical dystonias, and like I mentioned before, the seizures in epilepsy. They also had safety concerns. There were side effects that they were concerned about, such as nausea, weakness, but really they were concerned with the behavioral and mood changes that they saw, and in particular, people had suicidal thoughts or hallucinations. You know, and especially in groups of people who have neurological disorders, suicidal thoughts are always a special concern. So you want to be very careful to potentially give them something else that may worsen those kinds of feelings. So what they ended up saying, their overall conclusion, was that certain forms of marijuana can help with the treatment of some of the symptoms of MS, but that there's not enough evidence to show if it is helpful in treating some of the other neurological conditions, including epilepsy. The American Epilepsy Society highlights that most of the reports that are coming out that showed that marijuana was good for epilepsy are anecdotal reports, and that there's really no robust scientific evidence for the use of marijuana for epilepsy. doesn't mean that it's not effective, and it doesn't mean that it's not safe. It just means that at this point, we need to do a lot more research into the effective treatment of epilepsy using medical marijuana. The Epilepsy Foundation does support the rights of patients and families living with seizures to access physicians with directed care, including who can prescribe medical marijuana. They also call for the end of restrictions from the FDA in terms of clinical trials and research into medical marijuana for epilepsy. And they believe that somebody's treatment of epilepsy should not be determined by one's own zip code. So we know that state laws have been changing, and over the last 10 years they've been changing pretty rapidly. But the reality is that even though as state laws change, under the federal government, medical marijuana is still illegal. And as far as the FDA is concerned, it is not safe or effective for the treatment of any conditions, including epilepsy. We know that when we're trying to get a drug approved, from the time that drug is conceived to the time that it has gone through all its preclinical and clinical research stages, can take over a decade before that drug hits the market. So it is an incredibly long process to push a drug through the FDA drug approval system. And then once that drug is approved, it tends to be classified based on its potential for abuse, based on its efficacy, and based on its side effects and tolerability. Laws, especially here in the tri-state area, have changed quite frequently. So in April of 2014, the headlines in the newspaper for New York were medical marijuana could be legalized. And then 3 months later, the Compassionate Care Act was signed into law. And the Compassionate Care Act made medical marijuana accessible to people who have cancer, HIV/AIDS, ALS, Parkinson's, MS, as well as epilepsy. In New Jersey, we've seen that they've decreased some of the limitations on the number of strains that could be cultivated as of 2013. But even when laws are being passed by the states, there are still issues with being able to potentially open up dispensaries or have private companies be able to sell, because there are certain neighborhoods that really don't like the idea of having a dispensary on their corner. So different states have been doing different things. So quite a number of states have been approving medical marijuana for the use of various medical conditions. And a few states have not only approved it for medical use, but as well as recreational use also. And this is just a list of some of the states that do that. But like I said before, regardless of the states that are passing laws and lifting restrictions, from an FDA perspective, it's still an illegal compound. President Obama says, "I don't think it's any more dangerous than alcohol." And it really was the first time that a sitting U.S. president had made a statement for marijuana that was not against the use of marijuana. And he was right when he says he doesn't think it's more dangerous than alcohol. When you look at the attributable deaths to various substances, there are no deaths attributed to the use of marijuana, and part of that is because we don't see CB1 receptors located within the brainstem, and so it does not affect respiratory rate or your cardiovascular system. Over-the-counter drugs and prescription painkiller overdoses kills a significant number of people per year. The deaths attributed to alcohol is a significant number, but by far the deadliest drug of all is tobacco. When looking at the Gallup opinion polls, in terms of how our society's opinion of medical marijuana is changing, for the first time in U.S. history, the vast majority of Americans agree with legalizing marijuana. And that sort of change in the opinion of the American public to legalize marijuana has really been seen in the last few years. That's when we've seen the biggest slope in terms of people's changing opinions. Americans support ending federal crackdown on medical marijuana and think that the federal government should really respect the laws of various states. And when the question is asked, should making marijuana legally be available to doctors, and if they should be able to prescribe it to reduce pain and suffering, the vast majority of people polled were in favor of this. And you would think that most people who would be in favor would be young people, the people ages 18 to 29. But it's really people between the ages of 50 and 64 who are really in favor of this. In 2006, when asked whether smoking marijuana was a moral issue, 50% of people said it was morally wrong. In 2013, when that same question was posed, 50% of people said it was not even a moral issue. Now, as our opinions about the use of marijuana are changing, what we have seen is that there's an increase in marijuana-related emergency room visits. So clearly, it's not as benign as we may think it is. And when the question is asked, is marijuana addictive? Oftentimes, some people will say yes, and some people will say no, but we'll take a look and see if it meets criteria for addiction. So when thinking about addiction, the criteria include things like tolerance, any withdrawal symptoms, whether the person needs to take larger amounts of the substance to get the same effect that they were getting before, whether somebody has a really difficult time cutting back, whether it's really having a significant impact on that person's social and occupational activities, as well as if there's physiological dependence. And so a researcher at Columbia's Marijuana Research Lab, wanted to see if marijuana was truly addictive. And what she did was have people come into her lab to stay for 21 days, where they would get alternating doses of marijuana versus placebo. And they would monitor these people on a closed-circuit TV. They would monitor their sleep patterns, their food intake, shifts in mood. And what they found was that patients who had been getting marijuana and were switched to placebo were now having disturbances in sleep, they were having disturbances in their mood, and there was a change in appetite. And so it does meet the criteria for having withdrawal symptoms. Common withdrawal symptoms that we see with all types of drugs are things like changes in appetite, anger, sleep disturbances, depression, restlessness, irritability, and cravings. Then she wanted to see, well, could people maintain abstinence? And chronic users, 15 to 37%, are able to maintain abstinence from marijuana, which is the same amount of people who can maintain abstinence for cocaine. They also found that they exhibited withdrawal symptoms, insomnia, suppressed appetite, like we mentioned before. And there was also psychological withdrawal symptoms, so anxiety and craving. And it's really the psychological withdrawal symptoms that drives the relapse. The withdrawal symptoms from marijuana play a role in the ability to maintain that abstinence. And so it did meet the criteria for the unsuccessful efforts to cut down. So when looking at the impact that marijuana has on the person's activities, you don't necessarily see the same social consequences. So marijuana, people may not get into the same kind of fights that they may get into when somebody is abusing alcohol. They may not be able to overdose like somebody who uses heroin. They may not be able to have a heart attack like somebody who's on crack. But what they did find was that marijuana abuse is really a disorder about the absence of things. So people were cognitively slower and they were unmotivated. And because of that, there was a significant impact on important activities. So is marijuana addictive? And the answer is probably that yes, it probably is addictive. Most people don't experience significant problems, but there is a subset of people who do use marijuana that do experience some problems. And the American Psychiatric Association has labeled this as cannabis use disorder, and it affects about 9% of pot smokers. And these people have really standard addiction signs like failure to fulfill major roles at work, at school, or at home, failure to attend or participate in really important activities. As our opinions about the legalization of marijuana changes, we see that more and more adolescents and teenagers are using marijuana because they're seeing it as less risky. And while not every user is harmed, there is harm that can occur from the abuse of marijuana. Okay, so this graph shows that in states where marijuana has been decriminalized, adolescents and teenagers tend to use the drug a lot more. So we do know that marijuana can impact the brain, especially in times where the brain is really changing. And during the period from adolescence to the mid-20s, the brain is undergoing quite a bit of change. It's trying to make itself a lot more efficient. It's trying to essentially shed the neurons that it doesn't need and strengthen the connections that it uses every day to make itself a lot more efficient. And people who start abusing marijuana at a really young age, when we scan their brains later on, we can see that there is a change in the structure of their brain volume, and their white matter tracts are not as myelinated as we would expect. And so when you look at the brain of a normal brain, a brain that hasn't experienced high doses of marijuana, you tend to see a lot of activity noted by the red and yellow spots. But in somebody who has been abusing marijuana for a long time, that increased metabolism, that increased excitability is not as prominent. So the Center for Injury Epidemiology and Prevention notes that with alcohol, there's a 13-fold increased risk of motor vehicle accidents. With marijuana, there's a 2-fold increased risk of motor vehicle accidents. The combination of the two, marijuana and alcohol, causes a 24-fold increased risk of motor vehicle accidents. Looking at studies from 1999 to 2010 that involved traffic fatalities, alcohol stays fairly stable at 40%. But what we do see is that marijuana sort of tripled from 4 to 12%. One of the issues that prescribers of medical marijuana face is this idea of the naturalistic fallacy. So a lot of people who are not in the scientific community believe that because this is something that grows naturally in the ground, that it can't be that bad for you. When the reality is that not everything that is natural is healthy. There are things that are natural that are incredibly dangerous to us. Another challenge that prescribers for medical marijuana in epilepsy have faced are people who may not qualify for the drug. And so somebody who just had one seizure doesn't necessarily qualify to be able to use medical marijuana. If somebody's seizures are controlled, but they want to use something more natural, they don't necessarily qualify for the use of medical marijuana. People with an unclear diagnosis of epilepsy also don't qualify. And people who are not on standard anti-epileptic medications or treatments will not be prescribed medical marijuana. At this point, it is not intended to be used as monotherapy, as the sole therapy for the person. It is intended to be used potentially as an add-on in people who have medically intractable epilepsy. Some of the other challenges include the idea that that people have that there are therapeutic benefits because of what people have seen in the news or what people see online. There's this belief that there is a lot of scientific evidence for the efficacy and safety of medical marijuana in epilepsy. And like I showed you before, there were only 4 randomly controlled trials that we've been able to find, and those trials were really poor quality trials and were no better than expert opinion at best. There's also the idea that medical marijuana for epilepsy at this point is a science of convenience. There's a lot of differing opinions that are not necessarily based on facts or evidence because there's such a lack of scientific evidence. And there's a lot of political, social, and religious considerations to take into account. So when we think about risk and benefits, the FDA has to evaluate risk and benefits for the population. Providers have to evaluate risk and benefits for their patients. But patients have to evaluate risk and benefits in terms of their own personal values. And sometimes we can see all these things sort of conflict with each other. So where are we now when it comes to the use of medical marijuana for epilepsy? Are we at a place of no return? With the legalization of medical marijuana in various states, we're certainly going to see more users, and there may be a lot more potential treatment options, especially as regulations started to loosen and maybe we're able to do more trials. Hopefully there'll be more help for people who really need it, but there's also the potential that there'll be more people addicted to it, and there's the potential that there will be people who exhibit some cognitive symptoms later on because of chronic use. At this time, we know that there are a lot of questions that need to be answered, and more research needs to be done. You know, in conclusion, the human race has thousands of years of experience with marijuana. There's a wealth of information regarding the endocannabinoid system. There's well over 150 years of anecdotal evidence, but yet there's a lack of scientific clinical data. So we know that more work needs to be done, and we know that more questions need to be answered, and there's more data that needs to be collected. And so I'd like to leave you with this quote, which is by Benjamin Franklin: "An investment in knowledge pays the best interest." And at this point, it is in our best interest to learn as much as we can about the use of medical marijuana for epilepsy. Thank you. And if you have any questions, you can email them to us.